So we've heard a lot today about current and data-driven information from experts. But what about the proliferation of medical advice that our patients, our community members, and if we're truly honest, we ourselves sometimes ingest from unvalidated online sources? Dr. David Stukus, aka the social media powerhouse, yes, I'm known as the Allergy Kids Doc, will help us wade through the murky swamp of outdated and inaccurate asthma information on social media. Dr. Stukus is a professor of clinical pediatrics in the Division of Allergy and Immunology at Nationwide Children's Hospital. He started the Complex Asthma Clinic in 2011, which treats children with severe or difficult to treat asthma. Dr. Stukus holds multiple leadership positions in Quad AI and with the college, and is one of only 12 allergists invited as a member of the Joint Task Force for Practice Parameters. Dr. Dave, as his patients call him, is very active on social media and uses his popular Twitter and Instagram accounts to dispel myths and combat misinformation. Come on up, Dr. Dave.
Good afternoon, everybody. Thank you so much for being here. It's a pleasure. As Linda knows, I can never say no to Linda, so it's always wonderful to have to be invited to this great conference. So last year when I spoke here, I spent a lot of time going deep down the rabbit hole of online information. We're going to do that a little bit today as well, but I thought I would turn it a bit on ourselves and some of the outdated information that gets perpetuated and things that I see on a regular basis, which we kind of need to put an end to. So here are my disclosures aren't relevant, and here's what we're going to be talking about today. All right, so this is the crux of the matter. We get these outdated beliefs that just get ingrained in us, right? And it's so hard to change our practice or the advice that we give, and we really need to focus on individualized approaches towards management. You heard about that this morning. This is where we are with asthma management. It's not one size fits all, and there are no blanket approaches anymore. So we need to sort of undo some of these old mantras that have been around for a while. How many of you interact with people in your regular day-to-day life or job that say they've done their own research? Yeah, right? So they're mispronouncing the word internet search. So what they're doing is they're going online and they're looking for information, and this is the world that we live in. Everybody has information, the world's information at their fingertips with smartphones these days, and it's really helpful for all of us to type in the common questions that you get on a regular basis, go down the rabbit holes, and you're going to see some really bad, scary information, and fear-mongering, fear sells really well. And the harsh reality is that everybody's doing this. So this is the expectation that we have when we meet people. They already have preconceived notions, and we have to anticipate that the information that they're finding online probably is taking them down the wrong path, and it's misleading. And we need to help everybody with critical thinking skills. So just because you read something online doesn't necessarily mean that it's true. And then really with low health literacy, so health literacy isn't just the ability to read, it's the ability for people to understand complicated medical information and apply it to their own care, the care of their children. And we know 2/3 of our patients, they have low health literacy. So you combine that with some of the intentional misinformation, and these folks are victims. But we can help with that as long as we know what's going on. So I'm sure you're all aware of social media. I'm sure you're all active in social media in various regards. And it's interesting because this is where a lot of people are finding their information now. And there's generational shifts. So we know like Gen Z, they now go on Instagram or TikTok to look for things like places to eat lunch and restaurants. They're not going on Google anymore or Yahoo or things like that. So this is where people are actually going to get their information. And the reason that social media is so good at what it does, we're not the consumers, folks. We're the commodity, because they want us engaged for as long as possible, and they're selling to advertisers. And then it rewards extreme views. So if you spend any amount of time on here, your algorithms will shift based upon if you hover over a certain video on Instagram, the algorithm says, oh, other people that hovered over this video also like this video. And then pretty soon it can kind of shift things. So my whole Instagram account is filled with things from Disney World and corgis, but that's almost intentional. So some things that you will find, and it was mentioned about, fragrances and classrooms and stuff like that. So a lot of people say, oh, essential oils. There's nothing essential about these things, but sometimes people use them to treat asthma. And we'll do a couple examples of the misinformation before we turn on our heads. But, this is a great example of how when you click on these links, it's really important to see where they're going. So this is, something that, look, they put all these references in there and hyperlinks. So it makes it look official sounding. But if you actually click through, the first one was a study done in mice. We're not treating mice here, so it's irrelevant to humans that have asthma. Other ones look at non-asthma studies and they say, oh, these essential oils treat inflammation. Asthma has inflammation as part of it, so therefore it must treat asthma as well. That's not relevant either. Completely random or dead links. And then there's a couple that have really bad studies and bad methodology. And we live in a world where we have predatory journals. There's more online journals and access to information. You can find quote-unquote published research to support any position these days, but it doesn't mean it's actually quality research. And we can really help people understand that. So this is what we can teach ourselves and the folks that we interact with. We want to always, always, always check the source. We have to check the source, especially now. I'm not even going to talk about artificial intelligence and deep fakes and stuff like that. This is spiraling out of control very quickly here. Pseudoscience kind of rules. So pseudoscience is when you take sciencey sounding words and you apply them in a word salad of mumbo jumbo, pseudoscientific explanations. Inflammation is sort of the hot topic these days. This is where we're talking about cleanses and detoxes and all natural and chemicals are bad and things like that. And you see examples of this. I think I shared some of these last year of people have natural remedies for asthma, and this is WebMD, so it's supposed to be a reputable resource. But if you look at some of these things, there's very limited evidence to support them. And then we get to what if we're the source of the misinformation? So that's sort of the rabbit hole of stuff online. But now if we really look at this, there's a lot of outdated practices that many of us are recommending to people, which we need to move away from. And it's okay to acknowledge this is what we once thought was the best way to approach things, but things have sort of changed. So we're going to address a lot of those over the next few minutes. And hopefully I present information that makes you question, I just recommended this last week or something like that. But, all right, so I'm going to use some cases to kind of illustrate these points. And these are all patients that I've seen. I see this every day. This is my job, and it comes to me with all this misinformation. All right, so here we have a 4-year-old boy. Every time he gets a cold, he coughs for 7 to 10 days. His family was told that he's too young to diagnose asthma. It sounds like you were told that at one point as well. And then they were referred to see me to get tested for asthma. Does this sound familiar to anybody? Yeah, all right. So let's dissect this. So what is asthma? So we all know what asthma is, right? But it's really kind of basic. So asthma is a chronic condition that causes recurrent episodes of reversible airway obstruction. It can present with coughing, wheezing. Everybody with asthma has some form of inflammation at the heart of it. For some people, it's a really big deal, and we have to put them on daily medications to calm it down. For other people, their inflammation isn't that much of a big deal. All of them have hyper-responsive airways. So this is what asthma is by definition. With the airflow limitation, we're all aware of this. There's multiple things happening. So it's not just squeezing of the airways, so it's hyperreactive airways and the muscles constrict, but you also have swelling inside. And then the mucus-producing cells in people with asthma, it produces a very sticky type of mucus. So you get swollen, closed-off airways that are filled with tar, and that's why it's hard to breathe. So we have to address all of these things and help people understand what's going on. So asthma is a clinical diagnosis. There is no single test that says, yes, you have asthma. And then one thing that we always want to talk about is asthma is going to change. So when we have families, especially with younger children, 4-year-old boy, this is what their asthma is now. That doesn't mean that's what their asthma is going to be a year from now or 2 years from now. It often improves as boys get older. Sometimes it doesn't. But we need to follow this, and we need to change our management. And really, we're in this space now where we're phenotyping people with asthma. So phenotype is what are the shared characteristics. So when we say somebody has asthma, well, what kind of asthma do they have? Everybody should know that. Do you have mild asthma? Do you have more chronic asthma? Is it intermittent? Is it moderate? Is it severe? How frequent are your symptoms? And most importantly, if you're old enough to exhibit recurrent respiratory symptoms that improve with asthma management over time, you're old enough to be diagnosed with asthma. Now, most experts will say it's really hard to diagnose asthma in the first year of life, only because it takes time for those recurrent respiratory symptoms to occur, but there's no age cutoff. And I still see this sort of propagated today that, I was told my child they can't have asthma until they're 5 or 6 or something like that. That's just completely incorrect. All right, so for those of you, are you familiar, does this sound familiar, the Asthma Predictive Index? So this is something I use every day, and it's sort of an intuitive way to figure out which of those 4-year-olds with recurrent cough has asthma. So this applies to younger children, 3 years of age or younger, with multiple episodes of wheezing and or coughing. And if we look at the major and minor criteria, a parental history of asthma, so family history is a strong risk factor. If that child also has eczema or atopic dermatitis, they're raising their hand saying, I'm going to have an allergic life. That's their first outward sign. So if they have those respiratory symptoms, we say this is most likely going to be asthma. And do they have detectable IgE to aeroallergens? Minor criteria would be, do they also have food allergies? If you happen to have a complete blood count and they have elevated eosinophils, that would support the diagnosis as well. Or do they wheeze outside of colds? So this is both a prognostic and diagnostic tool. So if you meet these criteria with one major or two minor, there's an 80% chance they're going to have persistent asthma by the school age. If all these criteria are negative, they probably don't have asthma. They're just having wheezing because of colds, or you can have certain viruses that cause these symptoms or things like that. So this is very helpful for families of like, wow, they meet these criteria. I think that they're going to have years of recurrent symptoms, so we can help families prepare for their journey and manage this over time and monitor it. So I'm going to have pearls throughout. These are Dave's wisdom pieces. So pearl number one, if we have a young child less than or equal to 4 years of age and they cough for 10 to 14 days every time they get sick, it's asthma until proven otherwise, especially if they have eczema. That's what asthma looks like in young children. Now, could it be other conditions? Absolutely, but this is what we want to recognize and call it what it is. Pearl number two, yes, we have diagnostic tools to help establish if somebody has asthma, but we don't have a test that says yes or no, you have asthma. So we have spirometry and exhaled nitric oxide. So these are things that measure lung function and also elevated eosinophils inside the airways. You can have completely normal tests and still have asthma. You can have the worst asthma in the world, and if I listen to you with a stethoscope and you're not actually having symptoms at that time, I'm going to hear completely clear breath sounds. So this is just a one spot in time. If they do have obstruction, especially if it gets better with albuterol, then that absolutely supports a diagnosis of asthma, but that's not what diagnoses asthma. So we don't want to tell people that they have to have the test done to diagnose it. It's a clinical diagnosis. So our next case is a 7-year-old boy who coughs with weather changes and upper respiratory infections. And then his family's told, well, he never wheezes, so he can't have asthma. Again, these are all amalgams of patients that I've seen. You've all met these people as well. And diagnosed with reactive airways disease. Can anybody in this room tell me what reactive airway disease is? Thank you. Oh, this is amazing. I bet 5 years ago we'd had different answers. So asthma symptoms. So this is where we want to tell people, like, you don't have to wheeze, but coughing, recurrent cough, and a very sensitive indicator is if you're coughing so hard that you're vomiting, especially if you're vomiting up mucus and things like that, that's asthma until proven otherwise. Now, could it be pneumonia? But yeah, that's the whole clinical picture of, is this happening over and over again? Of course, you can have chest tightness, difficulty breathing, or respiratory distress. This was a great article from over 20 years ago, and I see people saying all the time, I don't want to diagnose asthma because, if they want to go to the military one day, we'll talk about that and other stuff like that. Well, that's all false. If we don't tell people that their child has asthma, then they're not going to know what to do when they have respiratory symptoms, because they're going to need, to be treated and have symptoms over again. So reactive airway disease really is not a term. It's actually the same ICD-10 code as asthma, so we just need to call it what it is. So pearl number three, if we have an unclear diagnosis, let's give a trial of albuterol. So albuterol, as we all know, is a bronchodilator. We can use this as a diagnostic and therapeutic trial. So if we're not quite sure what's going on, here's some albuterol. Let's teach them how to use it. Let's make sure they use enough puffs. Let's keep track of it over time. If symptoms tend to improve and they respond really well, that's asthma. If they use albuterol 15 times and their cough doesn't get better at all, that's probably not asthma. We need to think about other things. So that's how we diagnose asthma. All right. So as I mentioned, we really need to think through what type of asthma. So there's different types of inflammation, and as allergists and immunologists, we're sort of trained on, is this, what type of T cells are involved? Is it Th1 cells? Is it Th2 cells? For a lot of children, it's going to be more Th2, which is associated with allergies. They're going to have other comorbid allergic conditions. That's when they have elevated eosinophils. But this is important to think through because response to treatment is going to vary tremendously based upon what type of asthma you have. I'm not going to walk through this whole thing, but when you have the type 2 asthma, this is when we think like inhaled steroids and things like that. But if you have more Th1 asthma, then we may be more likely to not push the dose of inhaled steroids and use other ways to open up the airways, think about different biologics and things along those lines. So when it comes to management, we all know this, but we really need to clarify for everybody that's living with this this is a chronic condition. You're going to have acute symptoms. You may have chronic symptoms. This is where the different inhalers come into play. And then really it's all about education, management skills. We talked about low health literacy, but if I'm seeing somebody with asthma in the office and I have 15 minutes with them, at best, every 2 months, and that's if they have truly severe asthma. Some of these families are seeing once a year, and we have to give them the tools to manage this and recognize this in their children on a regular basis. So it really is more about education than anything else. I love this picture. This is from the GINA guidelines. So this is what I talk to families about all the time. So if we set the expectation that asthma is going to change over time and throughout the year, then it helps people really better understand, like, okay, we're in a period now where we have to increase therapy, and then we can likely decrease therapy once they're under better control. So it really should not be like a set it and forget it. And one thing that I started doing in the last couple of years, I talk to families, I say, let's be really thoughtful about whatever medication we're doing, because sometimes you start a certain medicine and you just kind of keep doing it every day, and then years go by, and it's important to think about, do we still need that medication? Why are we using it if things changed? So pearl number 4, everybody with asthma should expect to change this over time. We're all familiar with the autumn asthma spike, right? We're probably right in the midst of it, depending upon where you live, but it's been shown throughout the world it's like 22 days after the start of the school year. Why is it 22 days? Well, because schools are a cesspool, and that's about the incubation time for different viruses to circulate. And then depending upon where you live, that you combine that with either aeroallergens such as ragweed in the fall or mold spores, you get the weather changes, and that's why we always see the autumn asthma spike. So we should be helping people understand, let's get in for those checkups in August and September. Let's make sure we have a good plan in place. Let's make sure we're communicating with the school so that they have all their inhalers and everything that they need. All right, let's move on to a 12-year-old boy with poorly controlled asthma and severe exacerbations. And this young man was told that he shouldn't play football because exercise is bad for your asthma. Have any of you met somebody who's been told that? What an awful thing to say to somebody. My gosh. I mean, we really need to move past this. And again, this is just such outdated information. So our goals of therapy for everybody, so every single person should have the same goal. The goal should be, let's minimize your symptoms, let's minimize the burden of care, let's try to avoid side effects when possible, let's keep you out of the hospital as much as we possibly can. And then, but also educating, like, if you have asthma, you're going to have symptoms. So telling people that we want to make sure that you're completely asymptomatic, that's an unrealistic goal. It's a very realistic goal to say that we can get things under control. Now, sometimes we may need to step things up, sometimes we may need to step things down, we may need to talk about the environment and things like that, but this is what we should be striving for. All right, there's a poll in here. So is this something that you're going to read?
Okay, poll. Are we all ready? I see everyone's phones up. Make sure you're already locked in. What should be the approach to exercise for individuals with asthma? So I have 117. Let's take 1 minute, get your answers locked in, and then we'll read the results and continue with the presentation.
You need like Jeopardy music or something?
Okay, Bethany?
Okay, so B, 56% said B, and then 43% said D.
Okay. So we want to encourage exercise. Now, it's up to us to make sure if they can't find a way to exercise consistently, then we need to know about that, and then we can do something about it. So sometimes it's using bronchodilators prior to exercise, sometimes it's putting them on controllers, sometimes it's finding the right exercise for them to do. And then true exercise-induced asthma is actually pretty darn rare. For most people, they just have poorly controlled asthma, and then exercise is one of their triggers. So that's another thing to address as well. And then we have wonderful examples of professional athletes and Olympians that have been able to achieve, the highest level in their sport, and they have asthma. Something like 40% of Olympians have some form of asthma. So we want to recommend this. All right, so when we talk about treatment, we're all familiar. We have our relievers, which work very fast, and we have our controllers, which are designed to be used on a regular basis. Generally don't provide immediate relief unless we talk about combination inhalers and smart therapy, which we'll talk about in a second. So when we talk about inhalers, this is the most frustrating part of my job at this point. I'll see somebody, I will prescribe a medication, they'll go to the pharmacy and pick it up, their insurance company says, that's not covered. You have to use this one. We've already educated them on the type of inhaler, and they're going to switch it completely from an MDI to a dry powder inhaler, things like that. So going over technique is such a crucial part of what we do. And of course, with dry powder inhalers, these are very different. Generally, younger children can't do them very well because you have to have a very high inspiratory flow, and then you have to be able to hold your breath for several seconds afterwards. But it's, hopefully we can provide tips and tricks. And this was something I in a webinar that I gave for the Allergy and Asthma Network recently, there was asked, like, how do we educate people about this? So just having these tools in place of, like, here's how to use these inhalers, even if you don't have like the devices to practice and things like that, we can review this, and this is something that should be reviewed every time. One of the most powerful things, especially for those of you if you're going inside the homes or you're out in the community, ask them to demonstrate their inhaler technique. And I guarantee you're going to find steps that you can correct. And then don't just ask one time. Ask them next time you see them. Ask them again and again and again, and make sure that they're doing it the right way. So here we have a 9-year-old boy who was at school. He has known asthma, and he had increased cough and shortness of breath at recess. Went to see the school nurse. He had a normal pulse ox, no wheezing on exam. The nurse refused to give him albuterol because he already took albuterol earlier that day, and he was told to drink some water and walk it off. This is a real patient that I saw. When we have acute asthma symptoms, we want to bronchodilate. As I mentioned before, there's multiple reasons why you're having these symptoms. So we have short-acting bronchodilators like albuterol. We have longer-acting beta agonists as well. And now we have things like anticholinergics and antimuscarinics. So everybody should have some sort of reliever for them whenever they do have symptoms. And these are things that I've seen patients that, they go to their school nurse or they go to somebody else and they're treated with essential oils. That's insane. We already sort of talked about that. Like, that's a terrible thing to do. Or people told to, drink a sip of water, or to just walk it off, or to go outside. Or, they're given honey to treat asthma. Honey does not treat asthma. So we want to recommend and address these with families if they're being told these things. Also, when we talk about albuterol, we really, it's important to think about how we talk about this. A lot of times people are told this is your emergency inhaler, and I would beg everybody in this room to not use that terminology. Instead, we want people to be aware that it's their reliever or their rescue inhaler, because if they're told that it's an emergency inhaler, what happens is a couple things. One is they may not use it until they think it's time to go to the emergency room, or two, every time they use it, they may think they have to go to the emergency room. So we want to encourage them. And then when we talk about how much albuterol, this is another, if there's only one slide for the whole talk today, this is the one thing that has to go away. So the whole 2 puffs of albuterol every 4 hours, that is so outdated. And if we look at our guidelines, so we have our NHLBI guidelines, this was published almost 20 years ago, where it's recommended 2 to 6 puffs. If you look at the GINA guidelines from years ago, 4 to 10 puffs every 20 minutes for an hour. So we want to bronchodilate. We want to tell people that this is something that if you need to use it, you need to use it and use the right dose. And then when we talk about nebulizers versus inhalers, if you look at all of the evidence behind it, it's if you use the inhaler properly with enough puffs. So generally, you're going to have to use 4 puffs of albuterol to equate what you get through the nebulizer. It should deliver the same, the same efficacy. And we always want to use spacers, even if you have the best technique in the world. The way I think about it, the medicine sits as a liquid in the MDI. We need it to turn into a mist. It takes about 4 inches to do that. So even if you put this in the front of your mouth, most of the medicine is going to get swallowed and hit the back of your throat and not get in your lungs. Albuterol is very safe. Everybody says, what if the heart's going to race and things like that? Yes, we have some known side effects, but you're not going to really reach toxic side effects until you're in the ER or ICU setting with continuous albuterol. So we want to promote use of it, and it's very safe. So now we have a 6-year-old girl with frequent ER visits. She's been taking medium dose inhaled steroids for 2 years. Went to see her pediatrician. They said, we need to jack this up. We need to go to high dose steroid as much as possible. Let's add in montelukast. I see this all the time. So this is where we need to be really smart about our treatment. So single maintenance and reliever therapy, where we have combination inhaled corticosteroids and long-acting albuterol, specifically formoterol. It's one inhaler to rule them all. So here's your controller. You can use this whenever you have symptoms as well. It's a great way to treat asthma, and it's still significantly underutilized. This is highlighted both in the latest U.S. asthma guidelines. This has been in the GINA guidelines for almost a decade, I believe. So this is what we should be doing for almost everybody who needs to step up. I'm not going to read all this for you, but the resources are up there. It can go down to the age of 4 for older children as well. You can use this on demand. You can use it as your controller, increase doses whenever you're sick, things like that. So the next few pearls, before we increase therapy, we want to make sure they're using their medication the right way. There's zero indication to put anybody on high-dose inhaled steroids. It's just we don't have to do that. We're going to cross over into bad side effects, and you're not going to get much improvement even if you increase the dose. And then montelukast, for those of you who aren't aware, there's a black box warning on this. Did you all know that? Yeah, so anybody who is prescribed this, they absolutely need to be, discuss the warnings that you can have significant behavioral side effects after starting this medication. So biologics, this is where, we can target specific parts of the immune system. This is a wonderful treatment option available for all of our patients now, and they go down to various ages. There's different ages that we can, use in different biologics. This is where it goes back to the phenotyping of what's actually driving their asthma and what are the different parts of the inflammatory and immunologic cascade that we can target. So, all right, we have a 4-year-old girl recently diagnosed with allergic asthma, and their family was told to get rid of their dog. Yeah, right? That's the saddest picture I could find. This is heartbreaking. I see this all the time. Please don't do that. We don't need to get rid of the dog. When it does come to allergies, though, we can have both chronic exposure to things like pets inside the home, cockroaches, mice, dust mites, and then we have acute symptoms with seasonal pollen. But we always want to make sure, and this was also highlighted in the latest NHLBI guidelines, of if we're going to diagnose allergies, like we can do this, so we have testing available. There's so much overlap with symptoms from non-allergic rhinitis and other triggers with allergies. Let's clarify the diagnosis first. What are your symptoms? What's the story? This is just an overlap of all the different reasons why people can have runny noses and nasal congestion. It makes no sense to put somebody on antihistamines if they're having recurrent upper respiratory infections, but if they have allergies, we can diagnose that and we can treat that. So we want to clarify that. So the next pearls, all the symptoms that can occur from allergies can occur for non-allergic reasons. If we're treating nasal congestion and snot running down your throat, you're not going to fix that by medicine by mouth. You have to use a nose spray. So we have intranasal corticosteroids and also nasal antihistamines that are really effective for that. And please don't tell families to get rid of their pets. So I don't know why the arrows got kind of screwed up there. Sorry about that. Next, pearls, we have testing available that we can diagnose people properly. If it's negative, we don't need to treat them as if they have allergies. I have to put this in my notes to this day of like people come to see me, I do all the testing, it's negative. They keep getting told to take their antihistamines and to get dust mite covers and stuff like that. And then we always want to reconsider the diagnosis if symptoms are still there. So in regards to avoiding allergens, there's no one size fits all. This is all highlighted in the guidelines as well. There's multiple factors. So if you have dust mite allergy, you have to get covers. You also have to wash everything in hot water, remove all the stuffies from the bed. It's a good thing my 12-year-old daughter doesn't have dust mite allergy because the 75 Squishmallows would have to go somewhere else. If you're allergic to things outside the home, we want to keep the windows closed. It makes the bedroom a very safe space, and wash your hair and change your clothes. So it's not one size fits all. And then I don't know if any of you recommend or get asked about air purifiers. But this is straight from the guidelines. They really don't make that much of a difference. So if you think about it, it could be helpful for some indoor allergens or other exposures like tobacco smoke, but it's only going to work really well for that room that it's in. So it's not going to do a whole lot for the rest of the house. So these can be really pricey and expensive. If they already have them, that's great, but I wouldn't recommend somebody spend hundreds of dollars on these sorts of things. And then as we wrap up here, for those who do have significant environmental allergies that's contributing to their asthma, there is a role for immunotherapy. So this is where we want to make sure that this is the long-term treatment option. So we have the subcutaneous shots or allergy shots that we've used for over 100 years. We want to make sure that the person actually has allergies. So do you have symptoms? Do you have testing? Are you exposed? Because it makes no sense to treat somebody that isn't exposed to what they're allergic to. And then we really want to control their asthma because allergy shots can have side effects and actually cause acute reactions and wheezing. So we have to get that under control. And then we also have sublingual immunotherapy available as well. In the United States right now, there's only 3 products approved by the FDA: ragweed, grass, and dust mite. So it's not going to be very helpful for somebody who's allergic to tree pollen, and mold and stuff like that. But there are some clinicians that are using sort of making up their own drops and things. So just to be aware of that. So bottom line is, we don't want to settle for anything other than good asthma control. There's many outdated approaches. We want to clarify the diagnosis before we go down the rabbit hole of allergy, reduction strategies and things like that. And honestly, we live in this day and age where we don't have to settle every single person with asthma. Even severe asthma that sends you to the hospital, we have treatment options available, and we shouldn't settle for less. Do I have time for 4 quick ones? You do. Okay. Hypoallergenic dogs are like unicorns. They only exist in your mind. So all dogs have dander that comes from their saliva, their skin, and their urine. So it's a marketing term, and it doesn't matter if it's a Labradoodle or whatever. It's interesting, if you're allergic to dogs, you may only have symptoms around certain breeds, but not others. But we can't test for that. The only way you can tell is if you rub your face on it. If you get itchy, sneezy, then you have issues. Here, back to the military. So if somebody's diagnosed with asthma, this is a huge myth. They think that's why they don't want to diagnose it, because they can never go to the military. That's not true at all. You can clarify this and provide documentation that says that their asthma has resolved or they had childhood asthma. And there's a great resource through the college's journal. This was just published. This is wonderful. It's just a different way that there's all these conditions that we can help people clarify that can still help them serve in the military if they want to. And then milk and dairy does not increase mucus production. People are being told all the time to stop, drinking milk when they have colds. So what happens is if you already have mucus, it can make the mucus feel more viscous and thick, but it's not going to make you produce more mucus. And then caffeine and asthma, yeah, caffeine does treat asthma. It's a good bronchodilator. But how much do you need to drink? Oh my gosh. So we have effective options available. Don't tell people to drink 4 cups of coffee when they're having acute symptoms. All right, and with that, I don't know if there's time for questions. I'm happy to take any, but thank you all very much.
Thank you, Dr. Dave. I don't know if you looked around the room, and there's no shame in here, because we were all sort of doing this a few times throughout this, so this was needed. We do have time for a couple quick questions. Do we have a question from online?
Yes, we have a question from online. From the point of view of a school nurse, how do we encourage a spacer usage when it was not ordered by their primary care doctor? Does a spacer need a prescription?
It depends. Yeah, so generally you do need a prescription for it. It's something that's great. I love that question. So school nurses can serve such a vital role in the health of all these, these children. So reinforce it to the family. Just say, have you talked to your doctor about this? This is why spacers are important. And there's like homemade spacers that people have. When we got stock albuterol for schools, people were, coming up with different things. But yeah, they can just have that conversation.
Thank you. One more question. Yes?
So you said there to give 4 puffs of the albuterol, but all the forms that I received, the orders say 2. So is that going to change, or do we just still continue with 2? Or
Yeah, so this is, you're handcuffed by what is ordered or prescribed. I'm working on it. I mean, this is part of the education. Every chance I get to talk to pediatricians, and that is purposeful. But yeah, that's just such a long-standing myth. So, but it's also helpful, nothing bad's going to happen. If you happen to give 4 or 6 puffs, you're only going to help them. So, you're not going to get in trouble for that. So kind of keep that in mind as well. At least I would hope not.
Thank you,
Thank
Dr.
you.
Dave. Big round of applause, please.